Liz and Purva and their co-authors have written several very good recent articles in Forefront. I've enjoyed reading them all. I think there's more coming. We'll get to that later on in the discussion. But the one that's been on my mind lately has been, excuse me, the one titled Reengineering ACOs to Make Medicare Competitive. Excited to welcome them both to share their thoughts. So we have former director of CMMI, Liz Fowler, former chief strategy officer of CMMI, Purva Rawal. Um, Maybe we could start with a quick introduction from each of you and then also what you've been up to since your time at CMMI.
Yeah, thank you so much for having us. Really excited to be here, and also just want to acknowledge that I love working with Purva. She's really the brains behind the operation. So when we get to write together and do these events together, it's like twice the joy. Um, so as you said, Liz Fowler, former director at CMMI, and now having left CMMI last year, I am at Johns Hopkins as a distinguished scholar, working on actually trying to continue some of the work that we were doing at CMMI on ACOs and the future of Medicare and how to sustain a healthy Medicare program into the future. And then also doing some consulting and advising and sort of a portfolio approach to a job, but really excited to still look for opportunities to still have a level of impact on some of the policies that I care really deeply about.
Purva Rawal, thanks for having me. And it's a joy, like a year out of CMMI, to still be working with Liz and putting new ideas and hopefully big ideas out there for people to be thinking about. So just grateful, Martin, that you read the article and wanted to talk to us about it. Since I left CMMI, I've been, I guess, I'm doing exactly what Liz told me to do a year ago, I guess. We're doing policy research at Hopkins with her. I'm also an advisor at the Duke Margolis Health Policy Institute, and then have a number of kind of consulting projects, both in the kind of domestic value-based payment space, but also exploring some and doing some international value-based payment work, because this movement to value is broader than just in the US, and there's a lot to learn from what's happening in other places too.
Like I mentioned, the ACO article has been on my mind a lot lately. ACOs have turned 15 recently. They're 1 year away from getting their driver's license. I'm curious to set the table for us a little bit. What's been accomplished and what still needs work from your perspective?
Yeah, Liz, I can start if you want, and you want to jump in.
Yeah.
So, and Liz can speak to this part more. We both, Liz was sort of the architect behind many. At that time, they were kind of the major delivery system reform that was included in health reform back in 2010, but it was a really new concept at the time. It's not like ACOs were proliferating. It was a term that people were still learning and that was being coined at that time. And since then, we've learned a ton. They've, I think over the last 15 years, I would say they've really helped increase the focus on population health. I don't think we were talking about it in the same way, not just that, value-based payment, I think in general has, but ACOs in particular. They've resulted in modest cost savings, which a lot of people feel like underwhelmed by, but the truth is there hasn't been a lot that saved money in fee-for-service or original Medicare, and they are voluntary, so there's something to build on, I think, there. And a couple of people have told me it is the largest, but I never like to say anything definitively. So it's like the research part of my brain. So, it's probably the largest care coordination program that's ever likely operated in original Medicare. So to me, those are some of the, what's been accomplished. And now we have over 50% of original Medicare beneficiaries that are receiving care through an ACO today. And that's a tremendous reach. I think we're often focused on how much more, closing that gap between the rest of the 50%. Liz might want to talk about some of the accountable care goals that CMMI had set under her leadership. But it's been, as you said, Martin, 15 years. And given the challenges that are facing beneficiaries and the Medicare program today, it seems like it's a good time to reform ACOs and think about what we need them to do to address today's problems. So, in the article, we do a little table setting, like beneficiaries are facing complex health challenges, right? Every Medicare beneficiary, almost every single one, has at least one chronic condition. Half have 4 or more. That requires multiple physicians, care plans. There's real opportunity to move upstream to prevent and honestly manage chronic disease better. I think the benefits of advanced primary care over the last 15 years have become clearer in this country. We know that primary care-led ACOs, for instance, deliver more annual wellness visits. We know that advanced primary care is associated with lower system costs and better outcomes. and that we need more care coordination. And we've seen ACOs can deliver that. And then last, there are some real fiscal challenges facing the program. You know, the trust fund, the Medicare Part A trust fund, is projected to be insolvent in 2033. Spending growth remains high, and we've seen that ACOs have the ability to constrain costs. And so, you know, our argument here is that through a comprehensive set of reforms, ACOs can work more effectively to kind of tackle these big picture challenges. Liz, I don't know what you would add.
Yeah, I will add, and you asked what's been accomplished and what needs work. I think so first of all, I want to go back and acknowledge the sort of the vision from the Affordable Care Act was, you know, it would be great to have a way to coordinate care, manage care, to get the benefits of sort of an HMO type approach in traditional Medicare without having people have to leave traditional Medicare to enroll in an HMO or a PPO. If they didn't want to be in Medicare Advantage, and ACOs were really the sort of platform to try to do that. And, you know, could we put in place those incentives, financial incentives, care alignment incentives in traditional Medicare? And that was through ACOs. And as much as we've achieved in the last 15 years, I think there's still a lot of work to do. It doesn't feel like a permanent platform. It doesn't feel like an obvious choice. It's not actually a choice. Beneficiaries choose. They may have the option to choose Medicare Advantage plans or switch a Medicare Advantage plan. They don't choose an ACO necessarily. And so I think there's a lot of sort of open question of what is the future of ACOs if it's not sort of on an equal footing to other choices that beneficiaries might make for a number of different reasons. But and just making sure that it's going to be around. I think there's a lot of questions like, is this a sustainable platform? Is there a recognition by both sides of the aisle and sort of a continuity across administrations that this is the approach that we want to take if you're going to stay in traditional Medicare and as an alternative to fee-for-service?
One of the things I thought was maybe even a little bit provocative about the title was talking about making Medicare competitive and thinking about ACOs and Medicare Advantage as being in a sort of competition, albeit without a level playing field. I'm wondering if you can speak a little bit to that idea of competition, both between MA and traditional Medicare, and then also among ACOs as a lever for driving these changes.
Yeah, and you mentioned several other articles that we've been working on. I think they're all sort of part of a bigger picture, which is what are we going to do to make traditional Medicare stronger and make it a viable choice and make it a choice for beneficiaries and a place for them to go where it is on a level playing field if you don't want to be in Medicare Advantage, as I said earlier. But there's also what do we want to do to make sure that Medicare Advantage is working as efficiently as possible and that it's delivering the benefits and the care coordination that beneficiaries are looking for, that it's a good care experience, not just for the people who are healthy, but for the people that start to develop chronic conditions that need very high cost care, that need that sort of high touch. And I think we're seeing a lot of that happen in Medicare Advantage, but not uniformly. And so I think this is about, a rising tide lifts all boats. So how can we make sure that Medicare is on a sustainable footing for the future, both financially and for beneficiaries? Financially for the program and taxpayers, but also financially viable and healthy for beneficiaries. And so, the work that we're doing is really looking at how can we bring more transparency to Medicare Advantage, and some of the themes there are, could we do a better job of sharing information about what's working and what's not in a way that gives information not just to beneficiaries, but also to providers and also to families that are helping their loved ones make these choices each year. And then also for policymakers and those who are looking at making policy changes and adjustments to the systems. This paper is really focused on what do we do in traditional Medicare, and I really applaud. This is a theme I think that has been consistent of interest of Purva's throughout her tenure and probably throughout her career, is like how to strengthen primary care, how to make sure that care coordination is still in place, and how to make sure that we're driving towards a vision where anyone in traditional Medicare is in an ACO, is in accountable care, whether that be advanced primary care or actually part of an ACO. Or in Medicare Advantage. And so I think that's the vision that we had set out in the strategy that we laid out. I will say I think this administration has talked about some of the same themes. Maybe they use different language. Maybe they talk about it slightly differently. I think when they say we want to see fee-for-service go away, I've heard that coming out of some of the presentations. I don't think they mean let's get rid of fee-for-service. I think they mean let's bring more value-based care and let's bring more accountable care to traditional Medicare. So I feel like we're saying sort of the same thing, and there is a common vision there, or at least I like to think that there is. And so what we're trying to do in some of these papers is lay out the path forward to achieve those goals.
I was hoping you could talk me through your framework a little bit. And so there were sort of three pieces, starting at the top, driving broader participation in ACOs. And maybe, Purva, we can start with you. Like, what does that look like? How do we get more people in accountable care relationships or arrangements?
Yeah, and I think Liz said that one of the goals from the CMMI strategy when we were there, I think the guiding goal was getting all beneficiaries into these accountable care relationships. And it's like, what does that mean? That means you are in a relationship, a longitudinal relationship with a care provider, usually a primary care provider, that's at some level responsible for quality and total cost of care, right? So it's a longitudinal, comprehensive relationship. But to get everybody in, you got to get the providers in. You got to get the providers in the ACOs to be able to deliver care in a coordinated way. And one of, I think, the root causes maybe of some of the program participation plateauing, which is what we've seen in the permanent Medicare shared savings program, and even in some of the decision making around joining a CMMI model, are the financial underpinnings of ACOs. And again, we go back to the original question you asked, Martin, which was, we're 15 years in now, and we're still operating largely under that same financial kind of construct. So a couple of the things that we talked about, and lots of other people have, published on this as well, is benchmarking. So ACOs operate under a shared savings construct, as many of your listeners probably know. Some may not be super familiar with it. So that the ACO earns shared savings if their actual spending is below their expected level of spending, which is what we call a benchmark. And ACO benchmarks right now are historically, they're largely based on historical expenditures. So, what were my historical expenditures for the last 3 years, for instance? And then every year that ACO's performance or their spending is then compared to their actual fee-for-service expenditures, and that delta is, they get some percentage of that savings back. And this methodology, if you think about it, worked, or probably worked pretty well in the early years of ACOs, because there wasn't, people weren't operating under that value construct where you're actually like trying to manage the total cost of care. But 15 years in, that kind of methodology is subject to what we call a ratchet effect. So in essence, an individual ACO, if you're successful, you are increasingly lowering your own benchmark, which makes it harder and harder for you to achieve shared savings. And then there's kind of what we call a collective success problem in the program, that as ACOs become more widespread in the program, they're actually lowering Medicare spending, which also has that effect on the benchmark. So you think about it, it's like now we've got over 50% of our beneficiaries in ACOs. That collective success problem actually becomes bigger. And so then the benchmarks are extremely complex, as like Liz and I, we spent so much time hearing about the complexity of the benchmarks, the lack of transparency, and it's difficult. It's very complex work. So over time, you're really just reducing the financial incentives to save. And what that means is that there's less money to reinvest in care delivery and care innovation. So we put out some ideas in the paper for how to address benchmarking by moving away from historical expenditures and thinking about things like an administrative benchmark or a set growth factor that allows, that starts to decouple sort of historical spend from what it actually costs to deliver care in a value-based payment construct. And then the second is not only the benchmark, but how ACOs are actually paid. And how those payments should be structured to enable care coordination, team-based care, and care delivery innovation. So, one idea is ACO should actually have higher shared savings options, and that increasing their shared savings options actually incentivizes them to transform care delivery. You're going to invest more in transforming care if you think you're going to, if you have the business case to get more on the back end. And then one thing we heard repeatedly when we were at CMMI was that it's very helpful when ACOs are getting prospective payments. because those upfront predictable payments really give them the resources they need to deliver true team-based care, comprehensive care, screen and refer for things like health-related social needs. And it's especially important for primary care. One of the models that we that the team had designed when we were there was the ACO primary care flex model, which really focused on prospective upfront payments to primary care practices. And then last is we want ACOs to do more than deliver primary care. We want specialty care to be part of that whole person care delivery. And so ACOs really need flexibility to use what we call downstream payment arrangements, right? Even if a specialty provider isn't in the ACO, how can they create relationships with high value specialty providers to manage all of those chronic conditions that I talked about earlier that beneficiaries have?
Liz, the second part of the framework was around increasing integration and coordination at the community level. This part was really exciting to me. I used to work for Colorado Medicaid, and the interaction point between a community-based organization, safety net providers, and the Medicaid institution is a really hard problem. I'm wondering if you would talk about what that looks like for the traditional Medicare population and into what you would love to see ACOs being able to do.
We'd really love for ACOs to be working more closely with safety net providers, and this is another area I think that was a common theme in a lot of the work we were doing. And so how do you bring more safety net providers, first of all, as a general rule, into value-based care? And how do you then make sure they're part of networks and make sure they're part of caring for beneficiaries? Otherwise, I think you see, and this is what we saw when we first came on board. Someone showed us, do you remember this, Purva? It was who's enrolled in an ACO, and it was sort of mostly suburban beneficiaries. It wasn't reaching underserved areas. Part of that was because they weren't really contracting with safety net providers. They weren't reaching those populations. If you're not working with those providers, you're not bringing them into the fold, and so you're not going to reach 100% unless you figure out a way to bring them on board. And those connections, I think this really is a game changer for the beneficiaries and the healthcare systems to have these partnerships and make sure that we're addressing food insecurity, the health-related social needs. I think now we're calling them upstream drivers of health. And again, this is another point where I want to make that I think there is a common interest and a common thread. If you read closely some of the regulations that have come out of this administration, they do talk about upstream drivers of health. They don't call them social needs. They don't necessarily call them addressing health equity, but I think there is a recognition that some of these features and factors really do influence health outcomes. And so how do we make sure that there's the ability for ACOs to partner with community-based organizations beyond safety net providers and actually the community-based providers of those services and those types of benefits that beneficiaries clearly need to get and stay healthy. And there's a lot of evidence. Did you talk about the accountable health communities model, Purva?
No, you should mention it because those final eval results came out, I think today. It was like phenomenal.
Oh, really?
Like news. Yeah.
So the accountable health communities was a model that CMMI had tested, looking at screening and referral for some of these social needs, and found that actually 20% of beneficiaries reported 2 or more emergency, or let's see, I want to get this right. 37% of beneficiaries screened and reported at least one social need, and nearly 20% reported 2 or more emergency department visits in the previous year. So we know that need is significant. And what we found was that screening and referral, if there was this feedback loop of actually making sure those needs were met, we were able to reduce those emergency department visits and actually improve health. And I'm probably getting some of these numbers wrong.
No.
And correct me if I've got that not quite right. But unfortunately, the final report came out after the model had already ended. But we did see that the model was associated with a reduction in expenditures, 4% reduction in expenditures, 4% reduction in 5% reduction in emergency department visits, 7% reduction in avoidable emergency department visits. So I think we know that these connections need to be made, and And we were looking at ways of making those connections. And I don't know if you probably want to add something here, Purva, that I've missed.
No, I was going to say, to go back on some of the designing for safety net providers, and we saw that really clearly when we were at CMMI, that, we were adjusting the ACO benchmarks for those ACOs that were serving higher proportions of underserved beneficiaries. And we saw a doubling of community health centers and safety net providers coming into the ACO REACH model, for instance. So we know that and then in some cases we were testing upfront infrastructure payments. We were, having lower risk options for some of those safety net providers. What you saw was they were then able to come in and they wanted to come in. So I think that tells us moving forward, there are things that we can make permanent in the shared savings program, which is what we talk about in the article. Like, look, we've got some good evidence that CMMI has generated. We can take more permanent steps now to create, dedicated tracks or ways to get those safety net providers permanently into programs. And then on AHC, I think it was today that the final evaluation result came out. So a lot of the data that Liz presented, that held to the end of it held to the end of that 5-year evaluation period. And that was another model that it was designed under the Obama administration. It was actually mostly implemented and run during the first Trump administration. And then, the Biden administration closed it out. And so you see that continuity in really wanting to understand the role that transportation, food, housing play in health outcomes. And you saw, a pretty direct effect relationship between the two.
I'm excited to read that report and share it out with the health tech community. So the last piece of the framework was around enabling competition and choice by ensuring a level playing field. We have kind of like an internal joke about, it's like no one knows what costs more, Medicare Advantage or Medicare, because depending on who you ask, and people are always arguing about it. I'm curious, what would it look like for us to have traditional Medicare, I think they're calling it original Medicare now, be more competitive with Medicare Advantage?
Yeah, we talked a little bit about this earlier on, and I think, some of those features are, first of all, just aligning on choice. You don't make a choice to join an ACO or make an active choice to stay in traditional Medicare. And I think if you really want to have competition, let's reach a point where you can actually make this choice, and that active choice has to be a viable option. And I think what we see, and because of the payments and the way the payment structures flow, the payments to MA, and I think, depending on whose numbers you believe, but MedPAC has been tracking this for a number of years. I think the overall number, especially after the changes made to risk adjustment under the previous administration and phased in completely under this administration, it's, I think, about 15% higher now than in traditional Medicare. And those higher payments enable lower premiums, and then there's also a requirement for an out-of-pocket cost in MA, dental, hearing, and vision benefits, some of these health-related social needs, these upstream drivers of health. Those additional payments are used to finance a lot of what makes those plans more attractive. I think there's also the challenge in traditional Medicare that it is now the only program in the country without an out-of-pocket cap. So ACA plans require an out-of-pocket cap. Employer plans require an out-of-pocket cap. It's required in Medicare Advantage. Of course, Medicaid is low cost sharing because of the population enrolled. So traditional Medicare is the only program without an out-of-pocket cap. And so I think we need to think about those inequities created by those additional payments and how to think about a level playing field. Really, you have to think about the payment streams and then what those payment streams enable, which is this sort of set of additional benefits. You don't need supplemental care or supplemental insurance, Medigap, if you're in Medicare Advantage, because they're taking care of all of that through one sort of fell swoop, including your Part D drug benefit. So we have to think about how do we maybe through the payment system bring up and raise that bar for traditional Medicare and provide some of those additional benefits that people need. And then I think it becomes more of a choice. We were thinking about how to reduce out-of-pocket costs if people are in an ACO. Could we waive cost sharing, for example, for primary care, for high-value care? Is there something that we could do to sort of bring the financial field to be a little bit more level. And then again, you have to go back to this choice. Like we have to enable a choice, and the choice has to be on an equal footing. So I'm sure I probably could have explained that a little bit more articulately. There's also, just the quality measures at some point, and this is part of the transparency. People have to be able to compare the outcomes, the options, and the quality performance metrics. And we don't even use the same quality metrics across the program. So I think that's another area we can look at where there could be a more level playing field.
Yeah, like given who we're talking to today too, there's a lot of discussion in this administration about AI and interoperability and the role of health technology, and those could all be real accelerators on the quality measure side. For instance, like we could have a more aligned set of quality measures across, and meaningful quality measures across MA and original Medicare that allow people to make some more head-to-head comparisons about impacts on population health and quality. And then the only other thing as Liz, as you were talking, it occurred to me that for a long time, and I think this is a little bit of the motivation behind some of this work too, is for a long time we talk about reforms in MA and we talk about reforms to original Medicare. And when you take a step back, it's an entire program. And now we're at a point with over half of beneficiaries in MA and little less than half in original Medicare, where the reforms that we're talking about in each program should really reinforce each other and make the Medicare program as a whole stronger. And I don't think we want to approach, reforming either side of the program in a silo.
We're coming up on the end of time. And so I think where I'd like to end before I ask what's coming up next and what we should keep an eye on from you two moving forward is a conversation we've been having a lot in the community lately is around reflections around simplicity and complexity. And so if you can have a really simple program, and I think this is one of the draws of Medicare, original Medicare, there's no prior authorization, bracketing wiser and NEMT for the moment. And it's a fee-for-service model, so that's attractive to providers. And then Medicare Advantage is a little bit more complicated, but that complexity unlocks something, right? Like D-SNPs and C-SNPs have, there is some sort of theoretical benefit to being able to coordinate care across those things. And I'd be curious, 15 years in, how you're thinking about simplicity and complexity in a program like ACO, and what role enablers and conveners kind of play in helping manage that complexity.
I'll start, and I know Purva has views on this as well, but if we want all providers to be able to opt in and participate in value-based care and in these programs, it's got to be a lot simpler. It's got to be something they can understand. I think the conveners have played a really important role in recruiting and building infrastructure and making sure that the resources to succeed in value-based care are available to providers who want to join. We were looking at a way to try to do that through the tools of the Innovation Center. Like, could the Innovation Center provide the data that and some of the analytics that providers might need to be successful, so that you didn't have to be part of a whole network, maybe if you just wanted to stay an independent practice. I think we also need to get away from just continuously testing new models. And I know that there's a new model, and we didn't get to talk about this. Maybe that's another program if you want to go there. But
yes, please.
There's a lead model that's coming out. But at some point, people want certainty, and they want to know that the program's going to be there for the future. And I think now that we know what works, I think we need to build those features into the shared savings program and test within the shared savings program. I think, of course, CMMI likes having its own model, and there's some real value in that. But unless they're testing something that really can't be tried in the shared savings program, using the shared savings program for a platform and making that sort of the more permanent program for the future, I think is a really important takeaway if you want to make sure that the providers are looking for a place to go, and that place is going to offer the right opportunities for them at the level of risk that they're willing to take and able to take, and that the tools and data and resources are necessary for them to be successful in value-based care and in an ACO.
Yeah, the more that the pieces that we know are working, or directionally we know are working, are permanent, it frees CMMI up and its resources up to be testing other things and to be testing new innovations, as opposed to like a third or fourth generation model all the time.
So I was just checking Health Affairs Forefront really quickly. A couple weeks ago, you published Beyond Star Ratings, which again I would recommend to anyone. It was very interesting to think about how to wrap your head around comparing health plans, MA plans. What can we look forward to in the coming weeks, or should we just keep refreshing the Health Affairs page?
I think we're looking at sort of what is that level playing field as part of the same grant from Arnold Ventures. And then we're also, this is a question, and I don't know if you have how much time you have, but the way that CMMI does evaluations is really not working for the program. And you see so much out there that CMMI isn't working. We need to tear down CMMI because the models aren't working. They're not saving money. But part of that is the way that we design evaluations and the way that the statute has been interpreted by the lawyers at HHS. It sets a really high bar that is almost impossible to reach. I used to describe it as like reaching for a brass ring on a merry-go-round. Like the chances that you're actually able to generate net savings with 95% certainty into the future, into perpetuity, is almost impossible. And not only that, but you think about an ACO, when we talk about the Medicare Shared Savings Program, we see, look, we're giving shared savings back and Medicare gets shared savings. And we call that a success. In CMMI models, any shared savings that goes back to the providers counts against the net savings. And so it's almost like you can never dig yourself out of that hole. And it's something that really bothers me deeply that I think we're not looking at success in the right way. We started looking at and trying to measure the spillover effect of these models. And, that's a whole nother conversation. But we are doing some work on sort of how should these models be evaluated? How can we look at success differently in value-based care so we don't just point to all the failures and we actually have a way to talk about the success?
Yeah, it's like, policy organization businesses don't make decisions based on like the 95% confidence interval that is cited, right? There's like a practicality to the work that I think sometimes gets lost when we're held to this evaluation standard. And there's so much great information below that like line that we miss.
And I'll also just say, the access reimbursement rates came out recently, and if you were able to actually, show positive outcomes on cardiometabolic diseases, that's worth a lot more than $360. I mean, it just was like the cost savings is is an accounting identity, but we also have this broader question of, we're spending 18% of our GDP on this thing. Like, what would it look like if it was great? So this was a great conversation. I really appreciate your time. We'll definitely have you back anytime you want to come and talk ACOs, Medicare, Original Medicare, Medicare Advantage. And in the meantime, we'll be, like I said, click and refresh on Health Affairs Forefront and looking forward to your next article in the series.
Thanks so much for
You.
having us. Appreciated the conversation.
Thank you both so much. Have a great rest of your day.